Welcome everyone. This is lecture 13, and this series of lectures is on fluids, electrolytes, and acid base. The lectures accompany and explain my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I am Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. This is the book. You can find it on Amazon. More information you can find in the description. It's available as a paperback and also as an ebook. We are still on Chapter 1, Disorders of Water Balance, Hyponatremia and Hypernatremia. And we are still doing interesting case studies in dysnatremia, and this is Part 3. We're going to jump right in. Case number 11, hyponatremia due to hydrochlorothiazide. We have a 75-year-old woman presenting with a serum sodium of 128 3 weeks after initiation of treatment with hydrochlorothiazide, 25 milligrams daily for hypertension. She also had lower extremities edema. Hydrochlorothiazide was stopped, and instead she was started on an ACE inhibitor for her hypertension. 1 month later, her sodium is up to 134. She's asking whether she can take hydrochlorothiazide again for management of lower extremities edema because her sodium is good now. So what's the harm? It is not okay. This patient should not be started on any thiazide type diuretic because of her tendency for hyponatremia. This reaction is kind of idiosyncratic. If it happens once, it could happen again, especially in the elderly. Instead, she can be started on a loop diuretic like furosemide, torsemide, bumetanide, low dose for the management of edema. For example, torsemide 10 milligrams a day is good and it's long acting. Remember, never forget that loop diuretic increase free water excretion in the urine. So they are likely to cause hypernatremia, not hyponatremia. The reverse is true with thiazide. So you get more sodium excretion than water excretion, and therefore you can get hyponatremia. At any rate, whenever you start a diuretic, you should check electrolytes regularly and monitor not only sodium but potassium and occasionally magnesium. Case number 12, hyponatremia and poor appetite. Pay attention here. This is something you will see very frequently. 82-year-old man presenting to the emergency department with a fall. Serum sodium is 129. Appetite is poor. His only medication is candesartan for management of hypertension. On exam, he's euvolemic. Serum osmolality is 275. Urine osmolality is 155. Urine volume is 1.5 liters and urine sodium is 22. What is the etiology of his hyponatremia? Now, if we look quickly at the numbers, serum sodium is low, so that's obvious. Urine volume is not too bad, 1.5. Serum osmolality is 275, so this is hypoosmolar hyponatremia. But look at urine osmolality. It is low. It's only 155. Normal, you should get 400, 500. And urine sodium is also low. So what's going on with this patient? He's not eating. There are no solutes in the urine. There's no potassium, not much probably, not much sodium. He's probably not eating much protein, so there's not much urea in the urine. So this is why we have an overall low urine osmolality. So this hyponatremia is not due to SIADH. Urine osmolality is low, urine sodium is low. This is not how SIADH presents. Both should be high. His hyponatremia is due to low intake of solutes. This is something you're going to see a lot in the hospitals when elderly patients are admitted. Don't say this is an SIADH. Clearly it's not. If you calculate osmolar clearance based on the numbers I provided, you get 0.84 liters, free water clearance 0.65. But the concept is if you have low solutes, you're not going to pull enough water into the urine and therefore you're going to retain water. Now, this is what some people refer to as tea and toast diet because tea and toast obviously not much solutes in that kind of diet. So what do we do here? You restrict fluids and you increase intake of solids. And when you do that, actually in the hospital, you can notice that the sodium is going up and that urine osmolality is going up. It's fun to do. Salt tablets sometimes can be utilized. Oral urea packets, like we talked about before, also may be considered as well. Now, I want to clarify this concept further. Let's assume that we have a person with low intake of solutes, that solute intake in total, this is all the salts, sodium, potassium, urea in the urine, is only 250 milliosmoles per 24 hours. And let's assume that this patient can maximally dilute their urine down to 125 milliosmol per liter. So what does that mean? That you can excrete 2 liters of urine. So if each liter can contain 125, but not lower than that, if you have 250, then the person can excrete 2 liters. They cannot excrete more because, again, someone or anyone cannot urinate free water. There has to be solutes in the urine. So if this person maximally dilutes his urine, we're going to get 2 liters. So what does that mean? Any intake above 2 liters will be retained unless more solutes are consumed. Okay, so if this person drinks 3 liters and we don't want him to retain anything, then we need to add another 125 milliosmol of solutes. I hope that this is clear. If it's not clear, repeat that again because this is a very important concept. Case number 13. 70-year-old man with a known history of small cell lung cancer. He presents with hyponatremia, serum sodium 123, which is very common in small cell lung cancer. He is diagnosed with SIADH. How effective is fluid restriction? I put this question so we can review this study. In 2020, a prospective, non-blinded, randomized controlled trial published in the Journal of Clinical Endocrinology and Metabolism compared 2 things, no treatment versus fluid restriction in 46 patients with SIADH. Patients were either restricted to 1 liter per day, which believe me is very hard, almost cruel. Patients would complain to no end, versus no treatment for 1 month. Median serum sodium at baseline was about 127 in both groups. After 3 days of fluid restriction, sodium rose by 3 in the group with fluid restriction, obviously, and after 30 days it went by another 1. So 3 plus 1, 4. So from 127 it went up to 131. In the other group, where no specific treatment was done and no fluid restriction, sodium only rose by 1. So therefore, fluid restriction is indicated, and it was here effective. If you go from 127 to 131, well, you don't need much else. But maybe you need other measures because in reality, no one is going to comply with 1 liter per day, okay, especially at home. Case 14, fluid restriction again. 50-year-old man was recently diagnosed with SIADH. On exam, he's euvolemic, like you would expect with SIADH, by definition, actually. His laboratory studies reveal serum sodium of 127, potassium 3.8, serum osmolality 265. Urine studies show urine sodium 51, urine potassium 29, urine osm 321. Urine volume is 1.9 liters per 24 hours. He's asking about the utility of fluid restriction and how much he can drink daily. So you look at the problem, and I'm giving you urine sodium, urine potassium, urine volume, like I'm begging you to calculate electrolyte free water clearance. Let's look at the calculations. The volume of fluids he can drink without causing much further decline in his serum sodium equals insensible water loss plus electrolyte free water clearance. You need to add them both. Insensible water loss is about 0.8 liter per day. Electrolyte free water clearance can be calculated from this equation. I'm going to provide links to lecture 4 and 5 where we talked about that in detail. Basically, we need to add the urine sodium plus urine potassium, divide by 127, which is serum sodium, and then we get, if we put these numbers in the equation along with urine volume, 0.7. So what is the 0.7 liter? This is the electrolyte free water clearance, meaning this is the volume of urine that contains no electrolytes, electrolyte free. This is the water portion of the urine. So if the patient is excreting 0.7 of water into the urine and he's losing 0.8 insensibly, insensible water loss, add them together, what do you get? 1.5. So if the patient restrict his water intake, his fluid intake to 1.5 liter, he can maintain his current serum sodium. If he goes lower, then what's going to happen? He's going to have better sodium. His hyponatremia will improve. And if he goes higher, then what's going to happen? His hyponatremia will worsen. And this is assuming no further treatment, such as furosemide or salt tablets. Now, if you are taking an exam, a board type exam, this is an important problem. Few people would get it right, so make sure to keep that in mind and to keep the calculation in mind. The following lecture will be the final lecture on sodium. We'll present more cases and there. See you then.